We'll switch and move from cystic pancreatic lesions to recurrent acute pancreatitis and discuss the evaluation and management of these lesions. And so for that, I'm very pleased to introduce Ali Sederat. Ali is one of our faculty here and one of our former fellows who spent an advanced year at Michigan East, as Jim likes to call it, the University of Pennsylvania, for his advanced training, and we've been lucky to get him to come back to join us. So, Ali.
Great, thanks, Raman. And Dr. Scheinman, that was an excellent talk. Thank you. I think a theme for this morning for the pancreas talks is going to be not a whole lot of data and a lot of expert opinion, and that's certainly present here. So, this is a talk about a difficult subject that I'm sure you've all encountered. So the goals are to define recurrent acute pancreatitis, to discuss the evaluation of the first episode of someone that has pancreatitis for which the cause may or may not be clear, and then the subsequent episodes of acute pancreatitis, and to talk about a logical workup and management strategy. So just to define, this is what's used in the literature just to define acute pancreatitis. You need 2 of 3 criteria of abdominal pain suggestive of pancreatitis, enzyme elevation, and characteristic imaging. And as we know, there's 2 types. The necrotizing is where most of the badness happens. Recurrent acute pancreatitis then is simply another cause of pancreatitis after the first one. And the stress or the anxiety really comes from the so-called idiopathic recurrent acute pancreatitis. If you have an alcoholic who's clearly drinking a lot and they come back for recurrent acute pancreatitis, well, it's kind of a no-brainer. They may be difficult to manage, but that's not really the topic of this talk. So when I was thinking about this, there's really a few types of the idiopathic recurrent acute pancreatitis. The first is that a common cause is present, but you just haven't figured it out, and that's maybe either alcohol that's surreptitious or gallstones that hasn't been identified, or an uncommon but identifiable cause is present, or it's truly idiopathic. You've done an exhaustive evaluation and you really can't figure it out. And so there's question marks kind of come up. Is this unexplained? Is this recurrent truly? And that's an important point. Someone who has pancreatitis and kind of bounces back to the hospital because they had severe disease or continue to have symptoms, that's not necessarily recurrent pancreatitis. And then you think, is this truly idiopathic? So etiologies, most, as you know, in this country are alcohol and gallstone related, but a significant portion, about 1/5 or 1/4, are still termed idiopathic, and that's the topic. So the etiologies that we consider: hypercalcemia, hypertriglyceridemia, viral pancreativism, congenital abnormalities of the pancreatic biliary tract, such as abnormal pancreatic biliary junction, toxins and drugs, microlithiasis, SOD, tumors, genetic causes, autoimmune pancreatitis, and some other conditions there. And I've boldened some of the ones that we're gonna talk about. So drugs, there's an excellent review by Scott Tenner in the World Journal just last year. And lots of drugs have been implicated in various types of reports, case series, but most of the evidence is relatively poor. And there's very few medications where there's kind of challenging and re-challenging type data. One clinical pearl is some drugs can cause enzyme elevation without true pancreatitis, so it's important to distinguish that. But here's a list of drugs to just kind of keep in mind. I won't go over all these, but just to kind of have, obviously the 6-MPA azathioprine is important, and some of those other ones are there just for your reference. So when do you work someone up? This was an old study, but it's often quoted. 31 patients who had the first episode of unexplained pancreatitis, they were followed for 36 months. Only one of them had a recurrent attack. And that suggested that perhaps in the majority of people, if you can't figure out the cause of the pancreatitis on the first episode, maybe you can just leave them alone and see what happens. That's been challenged a little bit by more recent natural history studies that suggest a higher proportion of people, though still a minority, will have another episode of pancreatitis, roughly 20%, and a significant portion, though also a minority, may develop chronic pancreatitis, and those are obviously an important subset that we deal with. So why do we care? There's something called the SAPE hypothesis that Dr. Whitcomb had published about. That's called the sentinel acute pancreatitis event, and it's sort of analogous to liver injury and cirrhosis, that continued acute insults would lead to fibrosis that's irreversible. And so the point is to kind of stop that reversible insult, stop the cause to prevent the permanent damage. Somewhat analogous to, for example, alcohol use and cirrhosis. So what should I ask myself? This is kind of a key slide, and I think this is a good way to approach these patients in a kind of logical way. The first thing is this really recurrent acute pancreatitis versus a chronic pain syndrome where the patient's coming to the hospital and may have minimal enzyme elevation at some point in their life and got labeled as pancreatitis? Or is this a biliary type functional disorder, SOD3? That's probably the first question. Second question is there a common etiology that I've missed? Something like, surreptitious alcohol use, stones or sludge, things like that. Next question is, can I prevent future attacks? Should the gallbladder come out? Do they need to stop a medication? Do they need a sphincterotomy, et cetera? A very important piece of the puzzle is there already chronic pancreatitis present? Small duct disease that has not been detected by cross-sectional imaging and may be detectable by EUS, for example, is very important to pick up because these patients will come back to the hospital with so-called acute exacerbations of their chronic pancreatitis. They'll have enzyme elevations, stereotypical pain, and maybe they don't really need to go down a whole diagnostic algorithm. Maybe they just need their chronic pancreatitis managed, difficult though that may be. And finally, and perhaps most importantly, is there a neoplastic process present, especially in older patients? Am I missing a tumor? And we'll talk about that. So the first episode, the initial presentation, an H&P, social history, alcohol use, medications, family history, pancreatitis is somewhat important. Basic labs, LFTs, triglycerides, calcium, and a right upper quadrant ultrasound. Having LFTs that are 3 to 5 or higher upper limit of normal on presentation is highly suggestive of a biliary cause of pancreatitis. Triglycerides and calcium can be somewhat misleading on presentation because of fasting state or because of the effect of the pancreatitis with a binding of calcium to albumin, for example, and hypocalcemia being sort of hiding a true hypercalcemic state. So those tests should be repeated if the cause is still not apparent as an outpatient, and you see that there on the initial follow-up visit. The ultrasound also, initially, often that ultrasound is in an ER, noisy, distended bowel gas, someone's just kind of scanning over, maybe a cursory look. That may not be the best test to say, hey, they really don't have gallstones. That should probably be repeated at some point on a subsequent visit. So other things you can consider, maybe consider IgG4. It's often done. The yield may or may not be low. We'll talk about that a little bit more. Cross-sectional imaging, a CT or an MRI, plus or minus secretin, and EUS, genetic testing. These are things to consider at the follow-up outpatient visit when the patient's well and you still haven't figured out what's going on. So let's talk about some of these individual modalities. EUS, very near and dear to all of our hearts. It's safe. It's the most accurate test that we have available, I would argue, for gallbladder stones, CVD stones, and sludge, and there's good data to support that. It can detect tumors, such as cancer and IPMN. In the right hand, it's very accurate for detecting pancreas divisum. It's very accurate for detecting subtle, so-called minimal change or small duct chronic pancreatitis. And the yield for idiopathic acute recurrent pancreatitis is relatively high, 30%, including a significant proportion for biliary disease that was not previously recognized. So EUS, very important. MRCP, it can detect P. divisum or other anatomic defects such as APPJ. It's probably less accurate than EUS for small tumors and small sludge and stones. And I consider it alternative or complementary to EUS. I kind of like to have both, frankly, because I think it's nice to have both of them when you're evaluating one of these patients. I will say that MRI is although it's thought to be an objective test and EUS is operator dependent, not all MRIs are created equal. A little bit of motion can make a big difference. Quality of the coil at your institution can make a big difference. What protocol was performed can make a big difference, whether there was 3D reconstruction, et cetera. So to kind of, be very familiar with your radiologist and what they're doing and know what to ask for. If you want an MRI with contrast, an actual MRI, not just an MRCP, know if you have to ask that. At UCLA, for the most part, automatically we get an MRI with gadolinium with all our MRCPs, and I find that very useful. But most places, if you ask for MRCP, you just get a non-contrast view of the bile duct without a whole lot of other evaluation. So let's talk about some of these disease entities. Let's talk about microlithiasis. So there's sludge and there's microlithiasis, and we think of them as somewhat the same. They are actually different. Sludge is a viscous suspension of crystals, mucin, and glycoproteins and debris in the bile duct or in the gallbladder. Microlithiasis is actually tiny crystals. They often coexist in the same patient. Most of the time, we use them interchangeably clinically, and they behave the same. The only important difference in my mind is that in practice, sludge can regress. Microlithiasis usually does not. So in the sick patient that's in MPO or on TPN that develops sludge, when they get better, the sludge is in a significant proportion, and in some studies actually a majority will regress. Microlithiasis probably won't. So right upper quadrant ultrasound, what we think of the gold standard, actually misses a significant minority of stones in as much as half of patients with sludge. And the likelihood of microlithiasis in idiopathic pancreatitis with a gallbladder in situ has evolved. Initially, in older data, you can see it was very high, 60 to 80%, such that and a lot of experts used to recommend, and some still do, empiric cholecystectomy for all cases of idiopathic pancreatitis, and maybe we can talk about that approach a little bit later. Subsequent data much lower, and that's probably because of improved detection of gallbladder and bile duct stones with better imaging, EUS, and things like that. And it's undoubtedly an important, and some would have said previously, and possibly some still say, most common cause of recurrent pancreatitis. So microlithiasis, what's the best test? There's actually one good comparative study that bile crystal analysis is not as good as EUS. I've never done bile crystal analysis. I don't know if anyone has it available anywhere. To me, EUS, have you guys done it? I don't know if you guys have done it. But it was one of the things that people turned to look for microlithiasis, and it's not terribly sensitive or specific. This is a patient, that EUS image that you see of a gallbladder of a patient, very pleasant 40-ish-year-old Argentinian woman who came to our hospital a few times with acute pancreatitis, and as every Argentinian knows, they like their wine. And so she said, I drink 1 or 2 glasses of red wine a night. And so she was labeled, because she had 2 or 3 episodes of pancreatitis, as having alcoholic pancreatitis, and was labeled actually as chronic pancreatitis. And I was asked to do an EUS on her, and I saw this sort of starry skied pattern in the gallbladder, and I told her, I think you have microlithiasis. She went on to have a cholecystectomy, and she never had a bout of pancreatitis again, and she's very happy continuing to drink her Argentinian wine. So microlithiasis, what are the options? Cholecystectomy, obviously in a fit patient. Sphincterotomy will probably prevent pancreatitis and cholangitis, but patients who have their gallbladder intact have an up to 30% risk of subsequent biliary colic in a couple months after you've seen them. So if they can tolerate cholecystectomy, it's probably best. And there's actually good data that the least invasive thing, ursodeoxycholic acid, is somewhat effective for microlithiasis in terms of preventing recurrent attacks of pancreatitis. So what's the role of empiric biliary therapy with a complete negative workup? That's, I think, still a moving target, meaning do you just cut the bile duct or remove the gallbladder despite everything that you've done, normal LFTs, non-dilated duct, no stones on ultrasound, et cetera, et cetera. Some would argue that you should have an empirical cystectomy, arguing that the data suggests that it's a very common cause. Laparoscopic cholecystectomy is relatively low morbidity procedure in these days. And in fact, some can argue that biliary or pancreatic sphincterotomy for a patient where the indication is recurrent pancreatitis is much more morbid than a laparoscopic cholecystectomy for the same patient. So this is a little bit of a moving target, and I think you'll get a lot of different opinions, and perhaps we can talk about that a little bit later. So let's talk about pancreas divisum. It's the most common congenital abnormality of the pancreas. It's present in up to 10% of the population. And it's very relatively controversial as to whether or not this causes recurrent pancreatitis. The theory is that the dorsal gland is bigger, going through a smaller opening, so there's outflow obstruction, intraductal hypertension, which then leads to acute pancreatitis. And a minor papillotomy is thought to reduce the outflow obstruction and thereby prevent pancreatitis. So does it actually cause pancreatitis? Well, it's common, and most patients, 1 in 10 of you, roughly, will have pancreas divisum. But not everyone here hopefully has recurrent pancreatitis. So whether or not there's a cause and effect is somewhat controversial. Most of the causation data comes from endoscopic treatment trials, so there's a little bit of bias there, though there is at least one cross-sectional MRI trial that didn't have endoscopic intervention that suggested the incidence of recurrent pancreatitis was high, divisum was higher in patients with pancreatitis. One thing that we're finding more recently is that pancreatitis may be the initial event, divisum may be the initial event, but a genetic abnormality such as CFTR or SPINK may be necessary as a second hit to cause pancreatitis. Oops. So the response to the endotherapy, this was an interesting systematic review of 22 patients, 22 studies, 800 patients, and the response rate to endotherapy. And so you can see there's, depending on indication, variability. So in my mind, if you have a patient that clearly has documented recurrent pancreatitis, and they have no other cause, and all you see is divisum, I think there's decent data in a properly selected and counseled patient to offer minor papillotomy. The strength of evidence decreases when chronic pancreatitis is an indication, and it's somewhat abysmal when just chronic abdominal pain without obvious pancreatic pathology is present. I wouldn't do it for the latter indication. So sphincter Vodi dysfunction, similar type of a rationale. There's some kind of outflow obstruction leading to intraductal hypertension and acute pancreatitis. There's 3 types. There's no role, I would say, in 2015 for endoscopic therapy of type 3. It's less effective if there's already chronic pancreatitis present in terms of endotherapy. So again, very important to identify as best you can early changes of chronic pancreatitis in these patients. And I'll just kind of close the sphincter Vodi dysfunction for now and leave to Rabindra to take it up. But I'll just say that the role of biliary sphincterotomy, pancreas sphincterotomy, dual sphincterotomy, nothing in these patients continues to evolve. So don't miss the tumor. 10% of patients with idiopathic pancreatitis end up being diagnosed with a mass. That's a relatively significant number, and it'll generally be in older patients. What's older is, I guess depends on how old your physician is, but 40, 50, something like that, you should probably consider some kind of imaging, preferably EUS, when they've healed. There's probably no utility in doing the EUS when they're sick with the pancreatitis, as the pancreas will look abnormal, and you can be fooled both in the positive and negative way for a tumor. Roughly a quarter of patients with main duct IPMN will present with pancreatitis, and so that's important to consider. And make sure to visualize the ampulla endoscopically. So an ampullary adenoma is another type of neoplasm. So if you're referring patients, for example, if you're not doing the EUS yourself for that indication, look for that line in the endoscopic report or the picture of the ampulla, that the ampulla was normal or visualized. And my practice is that if I can't see it very well with the EUS scope because of tangential imaging or whatever, then I'll grab a duodenoscope and take a nice dedicated picture of the ampulla to prove that it's normal. So chronic pancreatitis, roughly 13% of patients with idiopathic recurrent pancreatitis will develop chronic changes. The difficult ones to diagnose, as we know, are the subtle, small duct, or minimal change. It can be very elusive. There's a little bit of a cause and effect type of a thing. What kind of came first, chicken or egg? EUS is relatively good in terms of a structural test. PFTs, pancreas function tests, are not done in many institutions, but in the occasional patient where there's a little bit of disconnect between your structural evaluation and your clinical impression, function tests can be considered. One thing to take home here is that alcohol and tobacco are independently very strong risk factors for developing chronic pancreatitis in someone who has recurrent pancreatitis. So, there's good data now to suggest not only should these patients quit drinking, they should also quit smoking. And I tell that to all my patients that have this. Autoimmune pancreatitis, the HiSort criteria, many of you are familiar with. We'll just kind of touch on autoimmune pancreatitis a little bit. Dr. Durazo, I believe, this weekend will be talking about IgG4-related diseases in a little bit more detail, but this is one criteria: histology, imaging, serology, organ involvement, and response to steroids as making the diagnosis. Sometimes a challenging diagnosis to make, important one to make, however, because it is responsive to treatment, namely steroids. And a little bit of retrospective data out of the Mayo that was very interesting. Roughly 4% of patients that were evaluated for an etiology of acute pancreatitis ended up actually having autoimmune pancreatitis by HiSort criteria. So that's an important number to keep in mind. 4% is not small when you consider that these are treatable patients. And then if you look at it the other way, 24% of a cohort of known AIP patients, if you look back retrospectively, they had criteria for acute pancreatitis. So it's something to keep in mind. Some risk factors that were somewhat nonspecific but were identified in this series were younger age, jaundice, abnormal LFTs, other organ involvement to suggest pancreatitis. So I would say that when you have someone that has pancreatitis, if there's evidence, if they have abnormal pancreas enzymes and abnormal liver enzymes, that should make you think of, a couple of things. Stones, obviously, an ampullary tumor possibly, or a periampullary head of pancreas mass, and autoimmune pancreatitis. Those are kind of maybe 3 things to keep on the differential, with stones probably being the more common. And obviously autoimmune pancreatitis is responsive to steroids, so you want to identify these patients if you can. So genetic causes, we're, I think, familiar with these patients a little bit, but there's 3 well-known and increasingly additional gene abnormalities that are related to hereditary pancreatitis. BRSS1 is a gain of function of trypsinogen. It's autosomal dominant. These patients are usually in families that have pancreatitis and are well identified. The importance here is that these patients have an elevated risk of pancreatitis. That's very significant. CFTR is an important one, and it's important because it's very common. And you don't have to have pulmonary cystic fibrosis. It's a different potential mutation to have the pancreas one. So residents often ask that question, why are you checking CFTR? They don't have cystic fibrosis. Well, it's a different manifestation, and there can be heterozygotes, and there's probably, in terms of expression of people that have that genetic abnormality, gene and gene environment interactions that actually lead to the phenotype of pancreatitis. SPINK is an interesting one. It's been implicated in the Indian subcontinent in patients that have so-called tropical or fibrocalculous pancreatitis. It's been implicated as the potential second hit in patients who have pancreas divisum, and so it's included in the panel of tests. So genetic testing, I think it's important, especially for young people, where and I used to not really be a fan of genetic testing because my argument was you're not going to really do a whole lot different. But I think there is a little bit of an elimination of stigma if you identify someone as having a genetic cause. Because as unfortunately, I'm sure you're all aware, there are patients that come to the ER with pancreatitis. They're labeled as alcoholics. They swear up and down they don't drink. So if you can identify a genetic test, it somewhat eliminates that stigma, for better or worse, and maybe makes their lives a little bit easier. That being said, genetic testing is not perfect, and there are probably there certainly are genetic abnormalities for which we don't have a test for, and probably the majority of those patients that are truly, truly idiopathic are only idiopathic because we just don't know what the genetic abnormalities are yet. It has implications for pancreas cancer. It's probably something to consider in a young patient, and in my opinion, it should be done under the guidance of a genetic counselor. So ERCP, this is almost the last slide, and I haven't talked about ERCP yet, on purpose. So I want you to think of it last, despite my love for ERCP and catheters and all that kind of stuff and cutting, and it's the last thing you should think about when you're dealing with a patient with idiopathic recurrent pancreatitis. But in any event, the hypothesis is that there's some kind of an obstructive cause that should be investigated and treated, whether that's microlithiasis, SOD, or divisum. There's some evidence that these disorders can cause recurrent pancreatitis, and there's evidence that future attacks can be prevented by treatment of these disorders. There are, however, inherent risks of ERCP. So ERCP, probably in 2015, almost never, and maybe I'll get some flack for this, but almost never should be a diagnostic test for idiopathic acute recurrent pancreatitis. We get enough information from EUS and MRCP for the vast majority of people, and certainly to outweigh the risks of ERCP in this population, so that it really shouldn't be done for diagnosis. And I'm going to go out on a little bit of a further limb and say that includes manometry. Post-ERCP pancreatitis is really the reason that we want to be very careful about this. Dr. Freeman published a very well-referenced review of his data, and you can see that in suspected SOD, 23% had pancreatitis. In patients that get pancreatitis from ERCP, we kind of think of that as, you got to crack some eggs to make an omelet or something like that. So the pancreatitis isn't necessarily that big a deal. What we really care about is severe pancreatitis. That's what really kind of gets people sick, and that's what keeps you up at night, keeps me up at night. The patients that we really want to avoid are those 3% of patients in this series that had these are the indication acute recurrent pancreatitis ended up with severe pancreatitis. And this is a very important, I think, slide. If you look at kind of, should I do an ERCP on someone? Look at that adjusted ARDS ratio for post-ERCP pancreatitis. A female with normal bili, you write somewhere on their chart, maybe SOD, you just kind of sprinkle that fairy dust on them, and they have a difficult cannulation, which these patients sometimes do, and you've increased their risk of pancreatitis 40-fold. So some take-home points. When you think of recurrent pancreatitis, try to, in your mind, see if you can categorize the patient as idiopathic or unexplained. You know, idiopathic is one of those things that it's idiopathic until you figure it out. So if you can figure it out, then they're not idiopathic, but understand that there's still a significant minority of patients that remain truly idiopathic, and they probably have an underlying genetic disorder that we haven't yet identified. Always think of a tumor in an older patient in the U.S. is a good test for that. Smoking cessation in everyone, genetic testing in the young. EUS is your friend. Think of ERCP very, very last in the absence of a clear biliary pathology. And I think I'll stop there and look forward to your questions.